Yay! Good morning, everyone. This is one of my favorite groups of people that are here in the room today in Wright Auditorium. So excited. Welcome to Pediatric Grand Rounds. Thanks to those of you who are here and all of those of you who are joining us by WebEx. Usual reminders for our WebEx folks is to make sure you're muted. Some embarrassing things have happened in the past, but I know that's not going to be the case today. And if you have questions or comments for our speaker at any time, feel free to enter them into the chat, and I will ask them at the end of the hour. And for now, I have the pleasure of introducing Dr. Faisal Malik, who is Assistant Professor at Pediatrics at University of Washington, Co-Director of Health Services and Quality of Care Research Fellowship at University of Washington and Seattle Children's, Interim Associate Director of the Center for Child Health, Behavior, and Development at Seattle Children's Research Institute, and an attending physician in endocrinology at Seattle Children's. He completed his pediatrics residency and joint pediatric endocrine and health services and quality of care research fellowships here at University of Washington and Seattle Children's. He leads the Improving Diabetes Outcomes Lab, dedicated to improving health and healthcare quality for young and young adults with diabetes, and he is also the Director of Research and Medical Co-Director of the Achieving Health in Emerging Adults with Diabetes program, designed to meet the diabetes self-management, psychosocial, and healthcare transition needs of emerging adults with diabetes. Wow. I'm so glad you had time to spend the hour with us today, and we're so excited to have you. Welcome, Dr. Malik. Thank you.
All right. Well, Sam, thanks so much for the introduction and the invitation to speak. I'm delighted to be here today to talk about a population I'm extremely passionate about supporting, and that is our older adolescents and young adults, or emerging adults, as many of us in the healthcare transition field lovingly refer to them as. So I have nothing to disclose. When I give talks about healthcare transition, I think what I'm routinely struck by is that wherever I am in the United States, whether I'm talking to a group in Massachusetts, pediatric endocrinologists in California, or a practice here in Washington, our fragmented healthcare system consistently limits us, no matter where you are practicing, in being able to provide the type of transition from pediatric to adult care that I know all of us in this room, all of us on WebEx want to deliver. And this image may be an extreme representation of what an emerging adult might be asked to do in terms of bridging the divide between pediatric and adult care, but I'll tell you, it's not uncommon for me to hear from providers that they often are unable to provide a reliable bridge from two different systems of care, one for children and another for adults. And so even if let's say we even built an architecturally sound bridge in this image, we may not always deliver adequate instructions on how to successfully make the most of their care when they're on the other side, or frankly, on the adult side, be prepared to receive them and take care of their unique needs in the adult environment. And so unsurprisingly, we routinely see suboptimal population health outcomes in emerging adults secondary to poor healthcare transition in the United States. So I think what's comforting for me is, like any transition, with some planning and some intention around the goals of the transition, you can begin to lessen the impact of the environmental shift an emerging adult with a chronic condition is being asked to navigate when moving from pediatric to adult care. I'm obviously talking to a group of physicians. Man, we have gone through countless challenging transitions, right? And I think if you take the time to be like, what were the factors that facilitated our success? Suzanne mentioned that I completed my pediatric residency here. I can absolutely think of times on my NICU rotation when the pager would go off related to an urgent C-section, where I felt wholly unprepared to take care of a critically ill newborn, but not because I wasn't prepared for the transition from being a medical student to a physician learning to be a pediatrician. Right? On the med school side, there were frequent assessments and tracking my progress as a student prior to my transition. I then engaged in a process with clearly outlined steps on how to apply, interview, and select a residency program. And then this culminated in me coming to a residency program that was really prepared to receive me, to orient me, and integrate me into the training environment here at Seattle Children's. So it was the structure around the transition that put me in a position to thrive as a resident, obviously assuming I did the other intrinsic work required of me, right? So I think too often when it comes to healthcare transition, we don't dedicate time to provide the structure our emerging adults need. So my hope is that at the end of the talk, you will be able to apply the core elements of healthcare transition to support the planned, purposeful movement of emerging adults from pediatric to adult care, that you'll be able to develop a healthcare transition policy that includes key components to support successful healthcare transition, and that you'll be able to plan for the tracking and monitoring of healthcare transition services in your practice. Okay, so I'm confident that most everyone in attendance appreciates the importance of healthcare transition. I mean, we've all taken care of patients that we've spent so much time taking care of, and now we're like, oh my gosh, I got to shepherd you to adult care, and I know it's going to be hard. But numbers never hurt in providing meaningful context. So recent estimates suggest approximately 1 million emerging adults with long-term conditions enter the adult system of care every year. And there's ample evidence demonstrating how ineffective transfers of care is associated with condition exacerbations, loss to follow-up, and increased utilization of acute care resources. And since I'm a pediatric endocrinologist and spend most of my time working to improve health and healthcare quality in youth and young adults with diabetes, I thought I would just share data related to type 1 diabetes to illustrate the impact of suboptimal healthcare transition. So the data is pretty sobering. Depending on which study you look at, anywhere from 11 to 41% of emerging adults with type 1 diabetes drop out of adult medical care in the first year of healthcare transition. So unsurprisingly, when you ask emerging adults about their transition experience, approximately half will report difficulties with the transition process. And I think what's most disheartening to me is that those who are lost to medical follow-up are usually the ones in need of education and support in the ambulatory care setting the most, right? Among those lost to medical follow-up, mean hemoglobin A1C levels are on average 1.5% higher than those who maintain medical follow-up. For those who don't look at A1C and think about glycemic targets, that means essentially everyone that's being lost to medical follow-up is not meeting glycemic targets. And retinopathy and other diabetes-related complications such as nephropathy are just much more prevalent in those who are lost to care. And I can tell you, and I see some pulmonologists in the room, some hospitalists, you can look at your literature for your respective field and you're gonna find comparable sobering statistics in your field of practice. So in other words, it's not just about the condition, it's also about the process. So I think to bolster your practice's work around healthcare transition, I feel it's helpful to first define it. So at its core, healthcare transition is the process of moving from a child to an adult model of healthcare with or without a transfer to a new clinician. Now, for most of us in this audience, the transition from pediatric to adult care is going to require a transfer to a new provider. But you can imagine how this may not need to be the case in their primary care setting, for example, if they're seeing a family practice provider, or let's even consider our pediatric oncology colleagues who see some patients well beyond the age of 21. At some point, these providers will have to work to help the patient move from a shared decision-making model of care that often includes caregivers to independent decision-making in an environment where there's less supervision and multidisciplinary support. So I think what we've already established is that healthcare transition should not be a passive process. It should be planned. It should be purposeful. So to me, and when we're going to talk about healthcare transition today, I define it as the planned, purposeful movement from a child to an adult model of healthcare with or without a transfer to a new clinician. So how well do we do with respect to transition planning as pediatric providers? I think you probably would guess that it's not very good. So the National Survey of Children's Health actually annually asks parents if they received transition preparation. And so this is the most recent data from 2022. And parents reported that only 18% of youth without special healthcare needs receive transition planning guidance from healthcare providers nationwide. Okay, so you could argue that perhaps we're talking about youth that don't have a chronic condition that they're managing, maybe are just going in for their annual checkups. Maybe there's just not enough bandwidth or urgency to provide them with planning guidance. So what about youth with special healthcare needs? So this would be someone with asthma in the primary care setting or type 1 diabetes in my world. Well, the numbers aren't that much better. So only 23%, or about less than a quarter of youth with special healthcare needs receive transition planning guidance from healthcare providers nationwide. And I think what's important to know is that there's now growing evidence to support the value of a structured transition process. So at a population health level, we see improved adherence to care and higher self-reported quality of life. And you can imagine that with the structured transition process, we might see increased satisfaction with care, and that is what they report, along with patients and families citing reduction in barriers to receiving the care they are in need of. And we also see improvement in healthcare utilization in the direction that is favorable, right? Such as decrease in time between the last pediatric and first adult outpatient visit, and decreased utilization of acute care resources such as emergency department visits, and decreased hospital admissions. For for preventable complications, let's say, and again, in the diabetes world, of diabetic ketoacidosis. So in other words, implementing a structured transition process can support improved patient health and societal outcomes for emerging adults. Okay, so hopefully we're all sold on the value of developing a structured approach to healthcare transition in your practice, but what's the best way about doing it? Probably the best resources that exist at this time is the 6 core elements of healthcare transition, which was published jointly by the American Academy of Pediatrics, the American Academy of Family Physicians, and the American College of Physicians in 2018. And what they represent is guiding principles around healthcare transition. As someone who engages in conducting pragmatic trials and quality improvement research, what I appreciate about the 6 core elements is that it is not designed to be a model of care, but rather a pathway or an approach that can be customized to improve the structure around healthcare transition and can be really customized to the complexity of the emerging adults that you take care of, as well as thinking about what your practice resources are in your community. So here's a version of the 6 core elements that I've modified and I'm using with permission from Got Transition, which is a program of the National Alliance to Advance Adolescent Health. And we'll use this as a roadmap for the remainder of the talk. But at first glance, what should jump out at you as you look at this figure is that there are core elements for both pediatric and adult practices to consider. So both sides of the healthcare transition equation have an important role to play if this process is going to be successful. So what are the 6 core elements for a pediatric practice to consider? The first is to develop a transition and care policy or guide for emerging adults and families that describe your group's healthcare transition process and what to expect. Next, you want to have a plan to track and monitor the receipt of healthcare transition services by the emerging adults under your care. Third, you want to conduct transition readiness assessments throughout the healthcare transition process to learn what skills the emerging adult needs to obtain to better prepare them for managing their own health and navigating the healthcare system. You want to create a transition plan that includes the development of a plan of care that summarizes an emerging adult's medical care and also includes a discussion and practice of an adult model of care. And you want to engage in transfer of care activities that ideally should include a transfer package with a transfer letter, really try to think about the final transition readiness assessments, some medical summary and emergency care plans, and if needed, legal documents that will be helpful for a new adult provider. And then finally, this is the part that is rarely done, and it's really challenging here to do in the US, is to confirm transfer completion. And that includes verification of attendance at the initial adult visit. And again, always taking a quality improvement mindset to this, as well as getting feedback back to the pediatric practice by the emerging adult and family about how that process went and if they felt prepared to transition to adult care. So recognizing the importance of adult providers in the healthcare transition process, there are 6 core elements to successfully integrate emerging adults into an adult practice as well. And it's interesting, when this work was initially started, it was mainly being led on the pediatric side, and there was recognition that, wait a minute, we need to have similar core elements on the adult care side as well. So again, you have to have alignment around your approach and a quality improvement mindset from the outset to refine your processes over time. So that's going to be key if you want your patients to experience the positive outcomes I outlined earlier. So not surprisingly, similar to pediatric care, the first 2 core elements for adult care include having a transition and care policy guide and a plan to track and monitor receipt of healthcare transition services. The remaining 4 core elements for adult clinicians is a focus on orientation and integration into adult practice, as well as a structure to that initial adult practice visits and ongoing care for emerging adult that will need to look different from what they typically do with their older adults and will likely require different resources. I primarily partner with adult endocrinologists, and I'll tell you, most of them primarily see older adults with type 2 diabetes. And so I'll tell you, when they see a 19-year-old show up as a new visit with type 1 diabetes, they have some of the same feelings I have when I was on call in the NICU. It's not a population they're comfortable taking care of. And I'll tell you, the patients, you got to remember the emerging adult here, right? They feel it, they know it. They're already like, I'm not sure I can trust this new provider, and I'm not sure I want to come back. And this looks so different than what pediatric care was for me. And so even if you are successful as pediatric providers to get your patients to go see an adult provider, they may drop out, and we see that. And so we've got to work with our adult practices to make sure that they're ready to take care of the patients that we have deep attachments to. All right, so for the rest of the talk, I'll plan to walk us through what to consider when incorporating the 6 core elements in your practice, and also share examples of some of the work taking place at Seattle Children's to support emerging adults with chronic conditions. All right, so as I touched on, the first step in creating a structured healthcare transition process is to develop a transition care and policy that formalizes your practice's approach. I think the most common mistake I come across is a practice or group engaging in healthcare transition efforts without carrying out this critical first step, right? There's always, it's just amazing. There'll always be a pediatrician who just cares so much about older adolescents and young adults and feels like, gosh, I got to do more for them. Or a med-peds trained faculty member joins a practice and they're like, hey, awesome, can you make sure that those emerging adults succeed? And so the passion is there, the intent is correct, but the planning isn't there. And oftentimes they'll build pilot programs, and then that one provider that was holding everything up leaves, and all of a sudden you no longer have a transition program again. So really you want to take the time to develop a policy that has buy-in from leadership, has buy-in from your own providers, your adult colleagues that you're referring to. If you do that, it's a lot of upfront work, but you're going to have more sustained success. And I think what I've learned from our experience in pediatric endocrinology, the development of a policy also provides an opportunity to align practices across both pediatric and adult institutions if there's a planned change in clinicians. So when we took on this work as a division to support emerging adults with diabetes, we did it jointly with our adult colleagues at UW. And that's because more than 3/4 of our emerging adults with diabetes went to UW for their adult care. It made sense to make sure that at least there was alignment with the adult practice that we were sending most of our patients to. And what's exciting is that because of that joint policy, that plan and alignment around how we're going to support it, we actually now have a formal program to support emerging adults, which is called the Achieving Health in Emerging Adults with Diabetes program, or the AHEAD program. And it's gone beyond just making sure they make it from pediatric care to adult care. It's now a program that really tries to support their self-management, psychosocial needs, as well as obviously their healthcare transition needs. And we're seeing some pretty exciting positive outcomes. Okay, so you're about to create your policy. This is the process that we went through. You have to think about what's going to be in your policy. Now, it's got to be manageable. What are the key things you have to make sure that you establish within your own practice? The first is, what age will your practice start the healthcare transition planning process? If you look at the healthcare transition literature, there is no right age to start this work. And I think a lot of it depends on the fact that each condition has different self-management needs. Resources are different at different practices. So you have to think about, I'm not going to say, if you look at godtransition.org, they'll say start as early as 12. And you can see how that might make sense in the primary care setting, where at 13, there's going to be a lot of changes around rights for that adolescent patient. But for us, and I'll talk to you how we approach that question, it's tough. Because I'm like, if I start that early, how are we going to have the resources to support all of the healthcare transition resources that we probably need to develop? And is that the right time? Is that when I'm going to have my emerging adults actually buy in to the plan that and the expectations that I'm outlining? When are youth expected to leave your pediatric practice? So again, having alignment there, not having a few providers are like, oh no, I'm just going to keep my patient until they're 23 because that's how I like to do it. It's not setting that youth up for success necessarily, and again, makes it hard for you to track your performance around healthcare transition. And then really where a lot of the work really, once you have alignment around age and when they're supposed to leave the pediatric practice, what will your practice offer youth and parent and caregivers to assist them in transition? And then how will you approach changes in privacy and consent that happen at age 18? It's really hard for a lot of our caregivers to let go. And so how do you support them in that journey as well? And then you got to think about how you're going to implement the policy. Who will share it? Who's going to discuss it? How do you make sure that not only the youth understands it, but the caregiver does as well? How is it put together in thinking about the cultural considerations for the population that you take care of or the language needs? How will you inform your staff about your practice's approach to healthcare transition? And again, that's that piece of buy-in. And then finally, how will you operationalize the practice's expectations for not just the youth, the parent and caregiver, but also the pediatric and adult healthcare teams? So I think now often, if tomorrow some of us were like, hey, I'm ready to do this, our natural inclination is to put together a group of multidisciplinary team members who are like, hey, I know this person really cares, they're hardworking, they have their heart in the right place, or they have bandwidth. And you're going to put a group together that's passionate about transition and develop a practices policy. But what I'll tell you is that it puts you at risk for developing policy that may not best meet the needs of the population you serve. So I would encourage you to involve key stakeholders in the development of a transition and care policy, because it will increase the likelihood that the policy you develop is acceptable to the medical providers, to the emerging adults, and their caregivers. So we actually have an advisory board which now exists of current AHEAD patients, didn't initially, but also parents of emerging adults with diabetes. It's probably some of the most interesting feedback we've gotten is from adults with diabetes who remember going through the process where they didn't have structure like this. And I think having their viewpoint of why this work is sometimes important is reminds you like, okay, it's worth doing this, even though it's hard. And making sure you have the right group of providers. Ultimately, like I said, our program is now designed to kind of meet the psychosocial needs of our population as well, because it has a direct impact on daily self-management for this population. So we have a psychologist and a social worker. Oftentimes, getting community members, and I think, again, diabetes, there's a lot of advocacy that goes around in terms of kind of supporting the needs of this community. So we have a local diabetes advocacy group representative from JDRF, the Juvenile Diabetes Research Foundation, as well as the American Diabetes Association. And they've been great in terms of, again, helping us also think about, what it's like at what's going on elsewhere in the country, and again, being a megaphone for why this program is important and how emerging adults should go through it here at Seattle Children's. All right, so the second core element is tracking and monitoring. So documenting progress in the process of healthcare transition is essential for identifying emerging adults in need of healthcare transition interventions. And I think too much of the time people want a perfect tracking system. It's okay to start with some kind of manual work on a routine basis initially, right? Get the process started, start understanding what are the data elements that matter to you that you're gonna need to track. But obviously, as processes and programs grow, there's significant advantages to using discrete data fields within the electronic medical record. And so I wanna call out what some people are doing here at Seattle Children's, but before we do that, just what are some data elements that might be useful to track? Well, definitely thinking about, did someone actually discuss a transition policy with the emerging adult and their family, right? This is something you want to make sure that you're documenting, and there's, no matter who's taking care of this patient, that that step has taken place. When did the transition readiness assessments take place? Have we started the discussion around transfer of care to an adult provider? If we have they identified an adult provider? What's their name so I can make sure I can send them my transfer package? And then the anticipated dates of the adult care visits, again, back to that kind of transfer completion core element. And I think in addition to facilitating clinical care, tracking discrete data elements really enables improvement initiatives that rely on the ability to measure a metric over time to define specific goals. So what's neat is here in the neurology division, they've actually decided to leverage the EMR to give best practice advisories to their providers about anyone who is 16 and has an ICD-10 code of epilepsy, to get this alert to say, hey, it's time to think about possibly starting the transition discussion. So I think it's really neat. And then, what they've done is not only obviously have this best practice advisory, and obviously keeping in mind that providers may not always have the time, that might not be the priority. There's an option to ignore the BPA, and it just populates the next time. But hopefully you'll enact it. And when you enact the best practice advisory, what it does is it starts this care planning kind of module within the patient's medical record. And then there are different components around it. So policy discussion, transition readiness assessment. And what they're doing is each time there's actually a discrete data field where they kind of can mark and say, hey, I've discussed the age that we transition, make sure that they're aware of the consent for care when they're 18, and even having some initial discussions around about transfer of care. So again, they've done a really nice job, and this is being piloted in neurology, and hopefully will be, once built, will be something that'll be accessible to all divisions within the hospital to consider using for tracking and monitoring of healthcare transition services that are being received. All right, so core element number 3, skill development is essential for successful healthcare transition and really includes cognitive and social skills to communicate and articulate health needs and preferences. So what we see in the literature primarily are general transition readiness assessment tools. Probably the most common that people have come across is the Transition Readiness Assessment Questionnaire called TRACK, which has been validated and used clinically with heterogeneous samples of emerging adults with chronic health conditions. And that's actually what the neurology group is using. And so here's the patient-facing MyChart, and you can see that because they enacted that best practice advisory and started kind of that episode of transition in EPIC, it now is populating an automatic message to the patient to complete a transition readiness assessment questionnaire. And what TRACK does, it assesses 5 domains. I'm giving you an example here. This one's for managing medications. It actually includes 20 items, talks about appointment keeping and tracking health issues, talking with providers, and managing daily activities. And then patients answer their questions on a Likert scale. So you can get an assessment. Every emerging adult is going to come in with different skills around healthcare navigation and self-management. And so this can be a really good way for you to triage, where do I want to direct my resources as I think about the transition process. So general transition tools may be useful, particularly when applied at an organizational level across multiple conditions. Specific self-management and skill acquisition for a particular type of chronic condition, though, may not be captured in that general assessment tool. So there's some growing consensus that condition-specific transition readiness assessments that address the medical, psychological, and cognitive needs of unique populations also has a role. And so that's actually what we did here at Seattle Children's. So colleagues here at Seattle Children's with colleagues at Cincinnati Children's, we actually worked to develop a diabetes-specific readiness assessment tool, which we call READY, so Readiness Assessment for Emerging Adults with Diabetes Diagnosed in Youth. And what I like about it, again, my job is to not only get them to adult care, but prepare them to be successful, not just with healthcare navigation, but self-management. And we'll talk about this at the end, but I really feel like this is an opportunity for us to address some of the gaps in knowledge that an emerging adult has, right? I'll give you an example with the youth that I take care of. Many of them are diagnosed when they're 5 or 8, right? They didn't get the education, their parents did. And then everything they learn from their parents. But now they know what the daily requirements are of managing their condition, but they don't always know the why. And so this is a great opportunity as we're trying to help the emerging adult, assume all responsibility for the medical care, to be like, I want to take this opportunity to be like, how can I support you with their diabetes knowledge? So we have questions around, do you know what a hemoglobin A1C level measures? What are the complications? And even more kind of emerging adult specific needs, like how does alcohol affect blood glucose, or how does diabetes affect sexual health and function? So again, what we find is what this does is when someone comes in and they say, hey, I haven't thought about this, or they've even said, look, actually, I've thought about it, but I still need lots of practice. That's a chance for you to engage the emerging adult and say, hey, I saw you want to learn more about this. Let me help you today. And you build that relationship, and they start building some autonomy, some mastery that then hopefully also translates into their daily self-management. So the Ready, you can, as you're thinking about your assessment tools, think about what you feel the needs are for your population, and then also think about, what are the resources around it? Can you provide the education in real time, or is this going to be too much for your group to do? So maybe you do something a little bit more general. Again, it has components related to healthcare navigation, as well as insulin management and health behaviors. So, the question I get when I talk to diabetes centers is like, they fill this out? And I'm like, yeah, they do. And they fill this out, and they fill out a depression screener and a diabetes distress screener and an anxiety screener. If you set the expectation and then you use these screeners, they will complete them. So I just want to highlight that. Okay. All right. Core element number 4, transition planning. I think this part is a little more self-evident. We're kind of getting into the point, the processes that I think we all know what they are and what is required to do them successfully. But when we think about transition planning, I think the part that we don't do well is we don't start the process early. So begin it early, and that's where, again, that discussion of deciding when as a group are you going to start talking about healthcare transition really matters. So what our stakeholder group actually brought up the fact that they wanted to start the process at the age of 16, and so a lot of the emerging adults were like, 15, I'm like starting freshman year in high school. I have too much going on, but 16, I'm starting to become independent with driving. I can see college and work on the horizon, and that gives me a couple years to like an on-ramp to start that process, right? So begin it early. You don't then have to cover everything in one visit. And then starting that process early is also helpful for the parent, and so it supports that gradual transfer of responsibilities that we know is critical for success with healthcare transition. And then take the time to educate them on the differences between pediatric and adult care. We don't do it. We're like the adult care providers will explain, but it's a culture shock when you arrive there. So take the time to explain that this is not what care is going to look like. You are going to have to ask for what you need, and to do that, you're going to have an understanding of your daily management. And then ideally try to provide specific referrals to providers experienced with working with the emerging adult population, and then work to prevent loss to follow-up. And that kind of brings me to the other side of the adult practices really taking the time to orient and integrate these emerging adults into adult practice. So in our program, we do we don't do the standard outreach that's done for the older adults with diabetes. We call them 3 times. And it's funny, there's a lot of adult providers like, I think, why are we doing so much hand-holding for this population? They should just get 1 call, and if they don't come, they don't come. And I think, and I want to call that out because that's the culture shift that they're going to have to navigate. There's this expectation that you're just independent, you know it. And for us, we're like, no, they haven't mastered it yet. They need more practice. And actually, even after I do all of this, you're still going to have to teach them some things or reinforce what I taught them. So just making sure that what does your orientation look like to adult practice? What does your integration look like? Keep coming back to the residency example. When we show up here, our orientation is not the same as it is for faculty. We all get orientations, but as an intern here, you get a 1-week crash course on how to be functional in this environment, right? And then you have structured mentorship that is training you on how to be independent as a physician. And then we even, I'm talking about some of the unique needs, and we'll talk about this for the final elements of just what are my needs, how are they different? We get a full 1-week intern retreat. No one else does. Why? I'll tell you, I needed that. It was really helpful for me to kind of reconnect, to remind myself, why did I want to become a pediatrician again? And why did I choose to train here? Those things matter, and it's customized to the population that you're thinking about supporting their transition around. All right, so finally, the core elements 5 and 6 are impossible. It's making sure they actually make it to that side, that they make it there, and that the other side is totally ready to receive them. And I think this is the part you're going to spend years and years on, and that's okay. You're just going to make that process better. For us, it has evolved into a really deep partnership with our diabetes colleagues at the Diabetes Institute, because what we learned is that we had to work together. If all these steps were going to be met, we were going to have to work together. And it now is, again, a program that spans both institutions. So we try to provide comparable care. And what happens is, we won't talk about some of the other populations that we serve in the program, but let's go back to that. I started the conversation with the 16-year-old about healthcare transition. So what we've done is that every patient with diabetes seen in our pediatric practice is referred to the AHEAD program on the Seattle Children's side. So they get to practice changing providers in an environment that they're used to. So that's step one. At that visit, I set the expectation of like, here's what your journey is going to be like around healthcare transition. You're going to learn today what you like about me as a provider, what you miss about your previous provider, and you're going to keep that in mind as you think about what your adult provider is going to look like and who you want them to be. In addition, you set the expectation for the parent that like why we're coming into this program is because it's time for you to start gradually giving the responsibilities around self-management and healthcare navigation to your emerging adult as much as they are able to do. What's nice is I'll tell you, so many of them, even if they're 21, may not still be ready to be fully independent. And so what we do is we transfer them to the Diabetes Institute, and they're still in the AHEAD program, and then we shepherd them until we feel like, hey, look, they've got all the knowledge that we can give them. It doesn't mean they're meeting glycemic targets, but they have the knowledge, they have the skills to navigate the healthcare system, they know how to navigate the adult environment, and then we transfer them to an adult endocrinologist. The last thing that I'll share about this experience, I think the other thing that we don't think about enough is just where these emerging adults are in their lives. So many of them are possibly going to college or getting a job. And 21 doesn't nicely fit into a time point where they're ready to transition. So what's nice about this program, especially for our college students, they love the fact that they're 21 and they move to the adult side, but they're still getting the same care that they're used to. And then after they finish college, we support them to going to an endocrinologist of where they're going to be living long term for the foreseeable future. So I'll close by saying that while I focus on the goal of having organized clinical process in pediatric and adult practices to facilitate transition preparation, transfer of care, and integration into adult-centered care, the ultimate goal, of course, is to improve the ability of emerging adults to manage their own health and effectively use health services. And the transition from pediatric to adult care obviously represents a perfect storm during which interruption of care is likely for multiple reasons. They're transitioning to a time of increased independence with their medical care. They're also navigating personal milestones like living alone, getting into a relationship, getting a job, going to college, all of which may be new territory for them. And so you can see how management of their chronic condition may drop down on their list of priorities, or again, they're not really ready to talk about going to adult care. But as I highlighted, I think this transition also presents us as medical providers an ideal opportunity to support mastery and self-management if the emerging adult is still struggling with aspects of their care, build autonomy and self-identity that incorporates a medical condition they might be living with, and be prepared to navigate a healthcare system that isn't specifically designed with emerging adults in mind. And so again, that's kind of what we've done with the AHEAD program. And I just want to share, I think that's what started us off as a structured transition process has evolved to really thinking about what other needs can we meet for the emerging adult as we're designing this transition process. And what's been exciting for us is that we now have some data demonstrating that emerging adults are a group that notoriously struggles with self-management. They have the highest average A1C when you look across the lifespan. So younger kids do better because the parents are usually the ones driving their management. At some point it clicks and they manage their their diabetes independently as an adult pretty well. It's that transition period that's usually really hard. So what we've seen in terms of looking at data from our program is that on average, at that first visit, the model adjusted to A1C, this is a linear regression analysis adjusted for age, race, ethnicity, diabetes technology use, and health insurance, is approximately 8.6%. That's kind of about what the national average is. But by the sixth visit, so less than 2 years into the program, their A1C has dropped by 0.5%, which again is really the gold standard for drug trials. And if you can demonstrate a reduction of 0.5%, it's considered clinically significant. So again, there's some opportunities as you think about doing this transition process. Obviously, it's not just about getting them to adult care. It's also thinking about what are their needs and can we engage them in their self-management, and I would argue that you can. All right, so in summary, implementation of a structured transition process can support improved health and societal outcomes for emerging adults. Pediatric providers play a critical role in supporting healthcare transition planning and successful transfer to adult diabetes care. An effective transition to adult care requires active involvement from adult providers to plan for incorporation of emerging adults into their practice. So with that, thank you. Evaluations are there. I'm sure Suzanne's going to want to talk about that. Yeah. Happy to take questions.
I'm going to grab a microphone.
Yep.
Forgot because I was so excited. Thanks, that's great. So for those of you in the room, if you have questions, if you can raise your hand, I'll bring you a microphone so our online people can hear you. And if you're online, feel free to type away.
Hi, Faisal. Do you want a softball or a hardball?
Let's go hardball. Hardball.
Thanks for an amazing talk, as usual. I have a question more about the concept of relational continuity as we're transitioning from kind of pediatric to adult space, and the sense that families or patients may not feel that we are working as a team. Like even in this model, it's still siloed, right?
Yep.
Between those two settings. So instead of building a bridge, which the AHEAD program is doing this, but like taking a step further and like thinking more about like a landmass, like should we co-locate care between that pediatric and adult physician just for a few visits to actually make the patient feel like you are actually functioning as a team here to provide this care? Thoughts on that, or is that just infeasible and just not
Yeah, I mean, so the answer
necessary?
is, I would say the answer is yes, but only if it's feasible in the environment that you're at. And so I'll tell you, so that's actually what happens in, I'll give examples from diabetes centers. That is how they do it. And if you're fortunate enough to be co-located, I think you should leverage that advantage, right? But the reality is most institutions are not. And to try to convince leadership, first of all, that this issue is important, right? Because the problem is they're like, well, they're not my patient anyway, right? Or on the adult side, well, they're not my patient yet. So it's really hard to be like, let me put resources into co-locating for a patient that they're not even sure is going to join their practice on the adult side. Or on the pediatric side is like, let's just get them out. It's harsh to say, but that is what we're talking about when we have finite resources in the healthcare setting. So it can be done successfully. Co-location's done a lot. I think if you have a MedPeds trained physicians, that sets you up for more success because you can have that continuity of the same provider seeing them on the pediatric side and the adult side. But again, not everyone will have the luxury of having a MedPeds physician in their group. And so I think this is what I was trying to highlight, that I think the process needs to be customized for how healthcare is delivered in your community. And so the answer is yes, if it's possible, but probably outside, if that's not naturally occurring, best to kind of prepare them for how do you do this at two different locations. And I think our model is a good example. So what we've done is replicated the same program at both sites. And so so even if you can't be co-located, and yes, I can practice on the Diabetes Institute side and the adult endocrinologists don't come here, but we meet monthly and we say like, we need to be aligned in terms of how we deliver care. And so we spend a lot of time being like, okay, like here's the issues I see on my side. So when I'm sending them to you, here's what they need. And I think what's amazing, I think it's hardening for the emerging adult to be like, oh, like I can change providers. First they change it within our own institution. Then they go across the way to South Lake Union and they're like, wow, I feel like everybody is communicating with each other. I think the issue why people always are like, we gotta just co-locate is because our communication is always poor. And the handoff of transfer is not what it needs to be. And so then the solution always is, well, we just need one person to do it all. And really, that's not going to be feasible. But I hear you.
I have like a second question.
Sure.
When you guys are developing those policies, are you aligning it? Sorry, when you're developing those policies between like kind of co-designing those policies, are you aligning incentives and metrics?
Yes, that's what we did. And that's what I would encourage you to do. And so, it's funny. So then I was like, well, I can't meet with every adult provider. All right, just meet with the one group that you send most of your patients to. Yes, maybe there's some equity issues about certain patients getting maybe a little bit of support, but learn how to do it well and then go to your other practice. And by the way, that policy you just developed with UW is not going to work when I'm talking to people at Kaiser. There's going to be some common elements, but it's going to be different, right? I'll just leave it at that.
Sorry, we were talking about Kaiser.
Yeah. Well, it's true, and they honestly want to be like, no, you got to see a provider in our program. And then I'm like, do they have experience taking care of emerging adults? And oftentimes they don't. And so then you're like, okay, well, so I'm gonna have to spend some time trying to be like, what are the needs of that group? And then maybe you come up with a different policy. Maybe you support your patients are gonna go to a Kaiser adult setting in a different way on the pediatric side. Point is, it's a lot of work, but it's worth it.
Yeah, so my question was, I saw that in the HEAD program it says one of the part is understanding health insurance. But
Yeah.
I feel like a huge issue would be like actually as they're transitioning to college, when they start figuring out, oh wow, this is what I have to pay for health insurance every month.
Mhm.
A lot of them don't purchase it. How does that work and falling through the cracks of people? I don't know if it happens so much in Seattle, but like for people actually young adults being able to afford healthcare and prioritizing that and actually seeing that continuity and going to those appointments that you've set up because maybe now they can't afford it.
Yeah, I so appreciate that question. And you're right, the data supports that this is the group that is most uninsured. And even if they're insured, they're underinsured. So it's a really tough piece. And what's interesting, the Affordable Care Act kind of changed the dynamic. So what used to happen is this conversation needed to happen on the pediatric side. And with so many of our emerging adults now staying on their parents' insurance plans, that conversation now needs to happen on the adult side. And I'll tell you, the adult side is just like, you should have already figured this out. So I think you're right. There has to be some intention around it. We in our program, again, once you start showing some positive outcomes, it's much easier to get resources and buy-in. And so we have a social worker that is also on the adult side to help them specifically with the health insurance piece. So before they graduate from the program, we have them meet the social worker before they go from Children's to UW, because there'd be some unique circumstances if they're getting a lot of uncompensated care, for example, here. Again, start that process, and insurance is going to be part of your lingo moving forward. And for some, it actually starts right at 18. But then also knowing that just because they're 22 and have been on the adult world for 3 to 4 years, I think that's the other assumption the adult providers make. Oh, they've already been in the adult setting for 4 years. I don't need to worry about it. They know everything they need to know. But actually, they've been on their parents' insurance this whole time, and now they're experiencing that transition. So do you have resources in place to kind of think about them? And I think you do have to be intentional around it. The challenge is like, how do you get the resources to support them around health insurance? And so variable from insurance plan to insurance plan and state to state.
Thanks. A bunch of questions online, some with a similar theme, so thanks for that. From Cora, great talk. How do you transition for those who are under-resourced or for those where English is not their language spoken in the home?
Yeah, I think with that, the best practice is the same as what it is when you were taking care of them in your pediatric practice. So I think this is an intensive process. So, Cora, no, I appreciate the question. And what I want to say when it comes to healthcare transition, I don't think it's any different than what we try to do in terms of the support that's needed for someone who, preferred language of care is not English, and if they're under-resourced, you're going to need to provide them with more support. And that was another reason why there was buy-in on the adult side of realizing that we weren't going to have everyone ready. There were some 18 and 19-year-olds that are absolutely ready to jump because of, the resources they had as a family and the education and health literacy they had, but that wasn't the case for everyone. And there was a recognition by the adult group that we're going to need to provide some comparable, more intense resources. Again, I'll call out that the adult providers were like, I don't understand why this program is getting more resources than I am. And so those are the conversations you may have to have because resources are finite. But I think, Cora, the best practices that I'm sure you're already engaging and living by are going to be what's important for this group too, when it comes to healthcare transition.
Thank you. And then kind of in the similar vein, when you transfer care to the HEAD program, how do you care for patients who move out of state for college or other reasons? Specifically, are providers licensed to practice via telemedicine in other states?
Yeah. Man, the pandemic was amazing because A, it allowed for telemedicine. But 2, it took away the requirements of you needing to be licensed in the state. So for our college students, we saw them through the pandemic, and we saw the value in them being able to be seen when they're out in Iowa or in Florida. And then we would obviously try to encourage and be proactive to be like, when is your summer break? When is your spring break? I'm going to see you in person at least once a year. Unfortunately, with the restrictions are back. And so while you can argue sometimes to say that you're providing specialty care that can't be provided anywhere else, it's hard to do. So then you're going to have to be ready. And this is, again, where the college planning comes into play of being like, oh my gosh, you're going out of state. So I'm going to have to accelerate this process for you. And that's why starting at 16 helps, right? Are you thinking of going to college out of state? All right, we're going to have a couple additional visits before you go to prepare you for that. And we're going to help you find an adult endocrinologist. The other thing that we usually do, because the permanent address sometimes usually is still here in Washington. So as long as they're coming back for breaks, usually that first year, like, look, we'll support your prescriptions, come in person, get through that first year of college. But as you're going through that first year, start working on identifying an adult endocrinologist that I can refer you to. So telemedicine has changed a lot, though, because at least for the patients that go to Gonzaga and Wazoo, it's really easy to support them throughout their 4 years.
That's amazing. That's a great question. Thank you. And one more in the chat from Caitlin Camfield. How often do you encounter situations when parents continue to meticulously manage healthcare tasks, either due to reluctance on the part of the patient or their parent to increase adolescent autonomy? And how do you address those situations in 5 minutes or less?
Yeah, no, that was the surprising part of this process for me. I don't know why. It's obvious clearly to the person that asked that question that that's an issue. At the time, I was just like, I got to support the emerging adult. But it turned out, so I think the change in provider actually turned out to be our biggest advantage, because oftentimes it's the parent that has a relationship with that previous provider and they don't want to lose it. And they have a dynamic that it's really hard to reinsert the emerging adult into, because they've been working with this provider for 10 years. So I think that change in provider really helps us in our program. But outside of that, it's, again, being really clear. We go over the policy. You're emerging adult. I think using the word emerging adult goes a long way. Like, they are about to become an adult. And so that's how we're going to treat them. My chart is another way to kind of leverage the change. So we start talking about it at 17, that at 18, you're not going to have access to the medical record unless your child is going to give you permission to do that. And start having those conversations with the 17-year-old to be like, what do you want my chart communication to look like? Are you going to have the account only? Are you going to share and have your parent have some ability to communicate as well, et cetera? So I think the different milestones with the patient portal is one opportunity. Having, again, a clear policy that you start at 16 and by 18, the parent is ready. And I'll also tell you, though, there is another group, and obviously when I sit down, I'm sitting to facing the emerging adult and not the parent. Those are all things that we do to try to facilitate a candid conversation with and be comfortable with silence. The last piece that I was going to share was there's also a group of parents that are like, thank you. They're like, I feel so guilty all the time about what my child has to do. I have a hard time letting go, but thank you for giving me permission to do that. So just know there's another cohort that's meticulously doing it only because they're driven by guilt and responsibility, and giving them an avenue to say, hey, it's okay. And you're doing the right thing by shifting responsibilities to your emerging adult can have an impact as well.
That's a really good point. Here, one more.
This was just an excellent talk, and I really appreciate it. I am a retired primary care physician, and I would like to ask how much you're sharing with the primary care doctor who can support your efforts, but not just in diabetes. Seeing a care plan like this would help with the adolescents who have mitochondrial disorders or seizure disorders, where they're going to have lifelong issues, and the more we know, the more we can help our patients as well. So how much are you sharing with the primary care doctor, or including the primary care clinic in this transition?
It's such a good question. I'm so glad you brought that up. Because it's not just subspecialty care or just primary care. There's overlap, and we have shared responsibility. So how much do we do? I'll tell you that we don't do enough. And a lot of that is, again, trying, I think how a lot of people approach transition, which I don't fully agree with, but is trying to be like, where does my patient go that I'm currently responsible for? And oftentimes that communication is not, we use the standard practice of how we communicate with primary care. So as a subspecialist, how I typically communicate is how I continue to communicate around when healthcare transition time comes around. But I agree with you that I think, and that's something I'll take back to our group, of how can we better partner with our primary care doctors in terms of identifying that transition as well and how they're being supported around it. It's something we can do better around. Yeah.
Hi, thanks so much for this talk. I feel like one thing I haven't really learned in residency is how to build connections with providers in the community. Like, I don't really know how, and I've actually multiple times in my continuity clinic been asked by parents, like, oh, you're leaving, like,
Yep.
do you have any recommendations for where I should take my child next? And I mean, I can Google as well as the next person, but I don't really know how to form those connections to actually make any recommendations for family members. And in this scenario, I can see how, like, obviously is a very clear delineation. We're at Seattle
Yep.
Children's, we're UW providers, so then you go to UW.
Yep.
But for general primary care, because it sounds like we don't do a great job for transitions for children who don't have any special health needs, what are your recommendations in terms of how I, as an individual provider, can make
Yeah.
those connections?
Yeah, we struggle with that a lot too. And so two things that I think are really helpful. You've got to have a way to get feedback back from your current patients. It's the easiest way to know where most people go, right? So use that as a resource. And again, have a process in place. So you're like, well, this is so unwieldy. Well, get a group together and get some stakeholders from your current practice panel and say, hey, I really want to understand what that process is like, and track 10 patients. Where do they go? What are the practices that they commonly go see? Obviously, utilize your network too to be like, where do most of my patients go? You usually have an idea. If you take, the problem is like where to get that data, but you can find it. But I think that the issue is not just about where are they going, but what's that process like? And what we have learned, and we've done this with some of our adult colleagues like up in Bellingham or in Eastern Washington, of just learning like what the processes were that worked and didn't, and then kind of use that to be like, hey, I want to make this better for you. How do I make a note? How do I make a transfer letter that is meaningful to you? I think that's actually usually the hardest part. You can spend time creating a transfer package, but if they don't know, if it's not in a form that they're used to or has the content that they need, it's not going to be helpful. So it's a lot of work. It's personal outreach. And it's doing it because, man, you have done so much for this patient for so long. Don't stop until you know they've made it to adult care. And that means sometimes, because of our fragmented system, that you're going to have to, as a practice, dedicate some resources to finding out where they go. But I'll tell you, you're going to feel better as a practitioner to know, like, it seems like a lot of upfront time, but once you have that process, it's actually turned out to be less work because you know exactly where they're going. You can prepare the family, like, I know this doctor, I'm going to send them this transfer letter, they're going to read it, I've talked with them. That's where a lot of my patients go. You're going to be successful. So yeah, a lot of it is on you. But if you're having challenges, which we did for a while, knowing like where in Washington State are a lot of our patients going, having some of existing patients already like kind of plan, be like, I'm going to let you, can you stay in touch with us? Can I email you? Again, figure out how to get stakeholder input about that process. And again, that is some of the best practices that we oftentimes don't do. I think the patients are the best resource, honestly. We're always like, let's talk to, which provider should I talk to? Just talk to the patients. And you'll hear like which ones did a good job and which ones didn't.